why the non-union occurs and how to handle it. I think unless we know why it occurs, probably it's difficult to handle it also. It occurs due to the mix-up principles. Comminuted femur fracture, immobilized, stabilized not rigidly, but immobilized with micromotion for a callus healing. Spiral fracture, lag and rigid fixation for a primary healing. Now this is the fracture. Most surgeons treat this fracture with this sort of a plating, which is a short plate, and this plate, which is this is destined to go into non-union. So this is not the treatment which you try to do it for that. For a comminuted fracture, short plate is contraindicated. Most non-unions can be avoided if long minimum 11 to 12 hole plates is used in a micromotion mode. And this is the only way in which you can do it. So the long plate, 3, 4, 5 screws, and last screw, one hole, leave screw here and screw here. Then there is a micromotion mode, and then it can be treated extremely well. This is the way in which you will be able to treat this fracture. Then you will be able to avoid a non-union. This is the one which is the commonest way after the introduction of this locking plate, the non-union has come in. Medial void, what is the current thoughts? It has been presumed that the non-union is because of the medial void. In AOS 2016, the opinion was predominantly long 11-12 hole plates and alternate fixation, and double plating and the medial support in the different forms most of the time is not required and in a primary treatment. And this is an Indian debate which we hear most of the time. So even in 1975, we did this 40 years back in a comminuted fracture like this, which is treated with the spacer plate. No locking plates are there. Now this is the fracture which was treated by a colleague. He grafted it because it wasn't united. He grafted it and he expected to heal. Unfortunately, the plate breaks. Now the only way in which you can treat this is by a rigid fixation. You put the double plate, you put in a graft, lots of graft in that area. You put a double plate and the fracture unites in a 9 months' time. This is essentially the fracture which can unite if it is a double plating which will unite. Now here was the fracture which was treated by a colleague 1.5 years after the earlier surgery. And the fracture again, here it appeared as if it is a callus, but it wasn't, and ultimately the fracture, it went like this. This is the one which is ideally treated with the nailing. You can do the distal femur nail and this will heal up extremely well. Distal femur nail is probably revived now after the introduction of the distal femur plate because the non-union rate is high, and that's the reason in the nailing the non-union rate is not that high. And in the non-union is recorded in 21% non-union in the distal femur, 22 in a distal femur plate. And this is also the non-union which occurs periprostatic in a distal femur. This is a fracture which can easily be treated with a single plate. And this will heal up with a good amount of fixation and a good function. But when there is a fracture, this is below the flare of the femur, periprostatic fracture, this is a fracture which will end up into non-union. And this is the one which goes on to non-union. And this is the one which has to be treated. The surgeon treats it with the single plate, is not going to heal up. Because this is the one which needs the double plating. And once you do the double plating, then only it will heal up. Because, as you can see here, here is the bone which is there. This is the bone. So when you do a plate only on one side, there is hardly any fixation to the distal fragment. And that's the reason why. When you do, there is only one screw which is not going to use it. So when you do the double plating, then probably the whole distal fragment is fixed up perfectly well, and then it will heal up. Here it was a double plating was done, and everything comes back to position. Here was the fracture again around the distal femur, and then this was the single plating which was done, and now there was a situation where whether I was wondering whether I should do a revision or I should do a repair. On the table, I felt this is probably repairable, so I went ahead. I did the bone grafting in this area because there was quite a lot of bone loss which was there. Did a bone grafting, double plating, and you can see here, bone grafting and the bone was compressed partially, so a short distance, so that here was the pre-operative area and here was the post-operative. Because I changed the spacer in the tibia so that it had to have a bigger spacer, and this fracture is held up. This is when I was out on a meeting. This is the patient I saw in the conference hall. And if in case there is a non-union like this into a patient who had a pre-existing osteoarthritis, there is no point in just trying to repair this and then do a replacement afterwards. Here, I went ahead, I removed the hardware, I did the primary total knee there, and all the graft which is available at the total knee, you can put it there and supplement it with the plate. And the fracture heals up extremely well with the whole function which is re-established. In this situation, in conclusion, I feel long plate to avoid a non-union. Double plate and nail in a non-union. Below the flare of the femur, almost always a double plate. Thank you.